Welcome and thank you for joining us for the joint webinar on uterus transplantation presented by the Transplant Pharmacy COP, VCA Advisory Council, and Women's Health COP. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. There is currently a viewership poll question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded and the archive will be available on the TX Pharm COP, VCAAC, and HUCOP hubs by next week. Please note that your lines have all been muted so that only the presenters can be heard for the archived recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the questions section in the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat section may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline or we will post the full question with the answer on the hubs following the webinar. Finally, when you log off at the conclusion of today's webinar, you will see a link to a short survey to complete. Please fill out this survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Silvi Shah, to begin our presentation.
Thanks, Anne. I am Silvi Shah. I'm a transplant nephrologist at the University of Cincinnati, and I'm very excited to kickstart this webinar on uterus transplantation. We have two amazing speakers today, Dr. Paige Porrett and Dr. Teena Sam. This webinar is a joint webinar on behalf of Transplant Pharmacy Community of Practice, Women's Health Community of Practice, and VCA Advisory Committee. Let me start with the introduction of Dr. Paige Porrett. She is the Director for Clinical and Translational Research for the Comprehensive Transplant Institute at the University of Alabama in Birmingham. She's the inaugural director of vascularized composite allotransplantation for the CTI. She actually started the third uterus transplant program in the United States in conjugation with her colleagues in the Department of Obstetrics and Gynecology when she was a surgical faculty at Penn. She's a founding member of the United States Uterus Transplant Consortium and is a board member for the International Society of Uterus Transplantation. She also currently serves on the VCA committees for the American Society of Transplantation and the American Society of Transplant Surgeons. So welcome, Dr. Paige Porrett. Now I would like to introduce Dr. Teena Sam. Dr. Teena Sam is a transplant pharmacist and the residency program director in solid organ transplant at Baylor University Medical Center. She has established and expanded transplant pharmacy services at Baylor University to provide comprehensive management across various abdominal and cardiothoracic organ groups. She has also been a pioneer and is involved in development of protocols, especially for the uterus transplant program at Baylor University Medical Center, and at the same time is very passionate about quality improvement. So welcome, Dr. Teena Sam. And now I would like to invite our speakers to start this webinar. Thank you.
Hello, everyone. Thank you, Dr. Shah, for that kind introduction. And on behalf of myself, this is Dr. Paige Porrett speaking, as well as my co-speaker, Dr. Teena Sam. We'd like to thank everyone for joining us today, and especially to the AST for promoting, I'll call it one of our very favorite topics, uterus transplantation, and to provide this opportunity to educate our colleagues in transplantation about this really important and new transplant. So I'm going to advance my screen here, which I'm struggling a little bit to do. And if one of our colleagues here can help advise me, I'm going to try a different approach. I got it now. That worked. Okay, thanks for bearing with me through that. So here is our disclosure slide. As you can see, Dr. Sam has no relevant financial relationships to disclose, and she's going to talk a lot about variety of immunosuppression medications as well with respect to off-label and investigational use. And I have limited disclosures. I'm a paid consultant for Janssen Research and Development that has no bearing on today's presentation. So here are our objectives today, which is to describe the current state of uterus transplant. We'll talk a lot about immunosuppression as well as the use of these drugs, as well as their complications. And then we're going to spend quite a bit of time talking about the special topic of management of immunosuppression in pregnancy. So I'll begin this portion with a discussion and overview of the current state of uterus transplantation. But before we go into that, we're going to pause here for a moment to let our audience participate in a polling question here. Dr. Shah, I'm going to hand it back to you to guide the audience through the poll.
Our first question is what are the indications for uterus transplant referral include the first option is uterine agenesis, hysterectomy due to fibroids, hysterectomy due to cancer, recurrent pregnancy loss, all of the above, none of the above, A, B, or C. So I think you all can see a screen live and just put your questions, answers there.
Dr. Shah, if I can add that we will, of course, I know we recognize these are guesses from the audience right now to collect your current knowledge. Your answers may change as we go, but we'll be sure to address the correct answer for the polling question in the content of the presentation. All right, so if I can add to this, I see G, A, B, and C as the most popular answer, 60%. And that would be, I would say, almost correct. And I confess, as the architect of this question, it's a bit of a trick question, and I'm going to save the trick until I educate you a little bit about the current state. All right. So I'm going to go ahead and advance here. And first, I'm going to take you on a whirlwind tour of some of the milestones in uterus transplantation and the history that's going to make this presentation easier to understand and more engaging for everybody. So uterus transplantation in humans really started in the year 2000, so about 20 years ago in Saudi Arabia with the very first uterus transplant performed in the world. Unfortunately, that graft failed shortly after its transplantation, and about 10 years later or so in Turkey, the next uterus transplant in a human was performed. Unfortunately, that transplant did not bear fruit for a very long time, and there was not a live birth from that transplant until almost 20 years later. Just within the last year or so, I believe the Turkish group has finally had a successful birth from that transplant. But there was quite a bit of struggle for a very long time. Our community, our global community, really accepts that the first successful uterus transplant that resulted in a live birth was due to the Gothenburg group in Sweden in 2014. And this was a culmination of many, many years of animal research, as well as other types of research to help promote the safe transplantation of a human being as part of a clinical trial. And in the wake of the Swedish successes, there have now been transplant centers all over the world that have popped up, including 4 that are currently recruiting patients here in the United States, and we'll talk more about them in a moment. It's hard to know exactly how many uterus transplants have been performed in the world to date. It's a very small community and we're very sharing with each other, but we have no formal registry that's, I would say, really gained popularity within the global community to share data with. And so what I'm providing you here is an estimate of about 100 uterus transplants performed in the world with about 30 live births. The transplant experience has been predominantly one of living donor transplantation. So this, for those of you other transplant professionals who know the history of transplantation, I would say this is a little bit of a backwards situation because usually we pioneer deceased donor transplantation before the adoption of living donors. This was not the case in uterus transplantation, and the deceased donor transplant experience is much smaller than the living donor experience to date. All of the babies that have been born to our knowledge are developmentally normal children, And I put an asterisk here to remind myself to tell you that the information I'm about to give you, you must take with a grain of salt. As a scientist, I will share that while these are developmentally normal children, number one, we do not have a lot of babies born yet, as you can see from the numbers I've already included. And the other caveat is that our follow-up is not long. So this is a picture of Vincent, the very first baby born from the Gothenburg trial, very first baby born in the world from uterus transplant recipient. And he, I think this year, is going to turn 7 years old, according to my math. And this is a recent picture of Vincent last year. So he's doing very well, and the other babies have done well. But again, we are very early in the field. So I'm going to introduce you now to the problem of uterine factor infertility, which is essentially the disease that is being treated with this new and novel transplant. So uterine factor infertility is a disease that affects many, many women and couples in the United States. And the numbers that you see on the screen up in the upper left here represent numbers from the United States, not the global community. So there's two types of uterine factor infertility, and I appreciate everyone bearing with me because I'm a transplant surgeon who knows a bit about this field, but I'm not a reproductive endocrinologist or infertility specialist. So the indications for, or I should say the types of UFI include absent uterus, or the uterus can be present but non-functional. And you can see some of the estimates here as to how many women and couples are affected by these two types of uterine factor infertility. I will tell you that of all the uterus transplant recipients to date, all of them fall in this category on the left. So we're talking about women benefiting from uterus transplant who had an absent uterus, either because they were born without one, which is the MRKH category. This is an acronym for Meyer-Rokitansky-Kuster-Hauser syndrome, quite a mouthful, but it's uterine agenesis, a disease that affects about 1 in 5,000 women in the world. And then there are a variety of, or more patients, I should say, who've undergone a hysterectomy for any type of indication. Now, fair enough that I would say advanced malignancy is going to be a rule-out criteria, at least with our current protocols in uterus transplantation at most centers. But there are certainly early stage cancers that for those patients who undergo hysterectomy that would be candidates for this procedure. And that moves me into my next point I wanted to make, which is that as I was a novice in this field a few years ago, I was really shocked to find out how many hysterectomies there are that have been performed in the United States. And so very quickly here, you can see from this publication in Obstetrics and Gynecology a few years ago, that from 98 to 2010, there were approximately around 500 to 600,000 hysterectomies in the United States alone every single year. And I did a little bit of digging and was able to calculate this following number, which is over this roughly 12-year period, that 300 and almost 80,000 hysterectomies performed not for cancer, because that would be a radical hysterectomy, were performed in women under the age of 40. So it's 380,000 hysterectomies, which is where I got this number. So in women under the age of 40, about 31,000 per year. So the MRKH patients have received many, if not almost all of the transplants to date. But with my next little panel here, I'll showcase my prediction, which is in the future that uterus transplant is really going to serve predominantly patients who've undergone hysterectomy and are therefore, of course, born with the uterus. So both patient groups can benefit from this. And here I'm showing you just a snapshot of some of the referrals we've received at UAB over the course of the last few months. And you can see depicted here in the orange that 60% of the candidates that have expressed interest in uterus transplant are deriving from this hysterectomy group. So these numbers obviously may vary from center to center, but I'd say are fairly consistent. So in brief, what is the need for uterus transplant now that you understand a bit about the disease that's driving this need? So right now, we don't have a great estimate about how many patients who are affected by uterine factor infertility might want a uterus transplant. But this is a complex subject that I'll treat very briefly here, but you can see from the bullet points that there's really no medical therapy other than uterus transplant available for absolute uterine factor infertility. And while adoption and the use of a gestational carrier are great options for many couples affected by this disease, it is not the best option or the preferred option by many of them. And as it stands, the use of a gestational carrier is the only option to have a biologic child for couples affected by this disease. And you can see by this map of the United States that surrogacy is illegal or obstructed in many of the states depicted here. And one word of caution, as I always frequently present this slide, as we educate people about uterus transplant and the need, is that I don't want you to interpret no legislation here, the states shown in white, as being, I'll call it a safe haven for the use of a gestational carrier, because I will remind everyone to run the following mental exercise, that if you were about to enter into a contract over something as important and sensitive an issue as the birth of your child, and for the contract amount of $80,000 or $100,000, it's really problematic to not have, I'll call it, appropriate legal backup if something goes wrong or if the parties disagree. So I don't want the white states to be interpreted as anything other than potentially, I'll call it, mild obstruction, because I think most parties that undergo the use or use a gestational carrier benefit where surrogacy is protected. So in short, the options are not totally accessible nor preferred. And so a third option for treatment of uterine factor infertility, really the only medical treatment, is uterus transplant. And it's a process, as you can see depicted here. So I wanted to just walk through quickly some of the milestones that a patient has to go through. The details of this process will vary with transplant center, but I'd say this is probably representative of what all the current US programs are doing. We undergo a medical evaluation, as is the case with any type of solid organ transplant, quite rigorous and detailed. And then once these patients are selected into the program, if they've not already created embryos through IVF for use with a gestational carrier, for example, that's when we ask them to do so. The patients then undergo uterus transplantation, either from a deceased or a living donor, depending on the program. And then several months after transplant, as long as the patient is stable, medically stable, then we'll go ahead and perform an embryo transfer after thawing from the cryopreservation before transplant. I should mention, of course, that immunosuppression starts at the time of transplant. So immunosuppression, which is today's topic primarily, is carried through this whole timeline past the transplant, including through the pregnancy. The pregnancy hopefully matures to a term delivery. We deliver these patients with cesarean section, and I'm happy to address additional details about why that's the case at a later time. And then one of two things happens. If the couple wishes to pursue another child, the graft stays in after the baby is delivered, and then several months later, we can loop back and perform another embryo transfer and repeat the pregnancy. Or whether it's at that time point or an earlier time point, the uterus is ultimately removed and immunosuppression is stopped. So I know that I'm moving very quickly through some of this information, but I wanted to share with you a little bit more detail about uterus transplantation and the US experience. Briefly, the very first uterus transplant performed in the United States is due to our colleagues at the Cleveland Clinic. This was performed in 2016, and that program has had many successes since that initial transplant. They are a deceased donor only program and have transplanted 8 patients to date. And as far as I'm aware, they are closed to new patients right now, primarily because of the pandemic. I believe that they are funded institutionally for 10 total transplants, and you can see some of their successes here. I think that some of these ongoing pregnancies have actually since gone on to deliver. Baylor in Dallas is the dominant program in the United States. They've done the most transplants with the biggest, I'll call it, variety of transplants. Even that said, 19 of the 21 transplants they performed have been from living donors. You can see some of their other numbers here, and I'd like to compliment my Baylor colleagues for, in particular, really leading this initiative of uterus transplantation in the United States. And they recently had a new milestone, which is they performed the very first commercial transplant in the US a few months ago. They've had excellent successes, as you can see, in terms of the number of live births, with one of their recipients, at least one, actually having had 2 pregnancies and deliveries off of her graft. The University of Pennsylvania is my prior stomping grounds before I came to UAB. We have done 3 uterus transplants there, 2 from deceased donor, 1 from a living donor. I put the X's here because we don't know how long this program will be transplanting right now. They are transplanting up to, as part of a clinical trial, up to 5 transplants. As I said, they've done 3 with outstanding outcomes, as you can see here. And then here at UAB, we're the new kid on the block, so to speak. Our program opened in October We are institutionally funded for 25 transplants, but have intent to go much bigger than that because we're, as we'll talk more about in a few minutes over the course of this webinar, one of our major goals is to help propel uterus transplantation into a realm where it's adopted by payers so that we can maintain access to this important transplant for all patients. We are the first to open our program outside of a clinical trial. So this is not research here at in Birmingham. We've had over 115 referrals since the program opened just a few short months ago. And we have one listed patient, and I'm actually expecting to list another patient in about 10 days. And with that, I'm going to turn over control of the slide deck to Teena here, and she's going to take it away for immunosuppression.
There we go. Sorry, I didn't realize I was muted. An integral piece of success of uterus transplantation is employment of immunosuppression. However, this field is unique in that immunosuppression is not given lifelong, unlike our other solid organ transplants, but rather temporarily to minimize risks for the recipient and the baby after birth. As with other solid organ transplants, so the goals of immunosuppression remain the same. So namely to prevent rejection, whether it be hyperacute, acute, or chronic. And as with other solid organ transplants, the risks of rejection must still be weighed against the short and long-term consequences of immunosuppression, which include infection, malignancy. In the case of uterus transplant, really thinking about fetotoxicity and maternal complications, which Dr. Porrett will review in detail in a little bit. And so really we have seen a paradigm shift in the area of transplantation, as the goal is not to save lives in uterus transplant, but rather to support life. With this comes unique immunosuppression management considerations to ensure optimal recipient and neonatal outcomes. With the immunologic insult of pregnancy, it's paramount to continue immunosuppression throughout pregnancy to maintain the organ. We will review the immunosuppressive regimens used to date in this growing field. The first uterus transplant was performed in Saudi Arabia in 2000 on a 26-year-old female. The recipient received induction with cyclosporin at 4 milligrams per kilogram orally 6 hours prior to surgery, and IV methylprednisolone at 500 milligrams at induction of anesthesia. Post-op immunosuppression consisted of triple therapy with cyclosporin, azathioprine, and prednisolone. Of note, which I find very interesting, this group used lymphocyte subpopulations, specifically CD4s and CD8 ratios, to monitor for rejection. This patient did experience a steroid-resistant rejection, but it did resolve with antithymocyte globulin therapy. Unfortunately, the transplanted uterus had to be removed due to infarction from mechanical occlusion of vessels, but we learned a great deal from this case on immunosuppression employment in uterus transplant. Since then, since that first case 20 years ago now, there has been an evolution in immunosuppression after uterus transplant. Jones and colleagues reviewed outcomes from the first 45 cases of uterus transplant in the world. Their review demonstrated that the most common induction regimen utilized has been antithymocyte globulin plus minus steroids, which was used in about 93% of the cases. As you can see, that one case of cyclosporin plus steroids was that case that we just discussed from Saudi Arabia. One case did use basiliximab. When it comes to maintenance, almost all centers in the first 45 cases, except one, which was that cyclosporin example we reviewed earlier, used tacrolimus as their calcineurin inhibitor of choice. Majority also employed mycophenolate as their primary antimetabolite. 4 cases did use everolimus, an mTOR inhibitor, along with reduced dose tacrolimus. Adjunctive steroids were used in only about 22% of cases. So majority of these centers did use dual therapy for immunosuppression. Now, at the time of embryo transfer, given the fetotoxic risks of some of these medications, those medications should be stopped, of which the most worrisome offendant is mycophenolate when it comes to teratogenicity. In the majority of those first 45 cases, patients were transitioned to tacro monotherapy. In 32% of cases, mycophenolate was switched to azathioprine, typically at least 3 months prior to embryo transfer, especially in the setting of rejection where monotherapy was not sufficient. Given the early nature of the field, and this is something that Dr. Porrett and I will emphasize over and over again, there is still much to be gleaned on adequate and optimal immunosuppression, not only just to maintain the graft, but also minimize risk to the recipient and the baby. And to do so, we must first understand complications from immunosuppression, both in other solid organ transplant populations, as well as the evidence to date in uterus transplantation, which Dr. Porrett will review with us right now.
So I'm going to take over here and discuss some complications related to immunosuppression. And here is our next polling question. Back to you, Dr. Shah.
Thanks, Dr. Porrett. So our next question is, the most common cause of graft loss is thrombosis, rejection, infection, or hemorrhage? Please type in your answers, and we would be discussing this later on as well.
Okay, I'll take it from here. And it looks like the audience knows the answer, which is 53% thought thrombosis, which was choice A, whereas B is rejection. Quite a few people thought it was rejection as well. That's a great guess. Thrombosis is the primary cause of graft loss, although obviously we're about to discuss the many complications other than graft loss that can occur because of immunosuppression. So with that, we'll move off of this to the next slide. And I've compiled here, I'll call it complications, this short list. So this audience is no stranger to many of these complications of immunosuppression. Immunosuppression obviously absolutely required for the success of all of the transplant patients that we serve. However, it is not without its toxicities and its problems. So we're going to focus today on many of the following topics. I'm going to spend a slide talking about infection and rejection and uterus transplantation. I know Teena will be talking a little bit more about rejection in a few minutes. I'm going to skip over the important complications of wound healing complications, diabetes, and the metabolic side effects such as hyperlipidemia. These are all important in uterus transplantation nonetheless, just as they are in other transplant recipients. You'll hear me discuss a little bit about bone marrow suppression, and then we're going to spend the majority of the time talking about renal dysfunction and some of the specific pregnancy complications. So I apologize that this is a busy slide, but I wanted to showcase some of the outcomes and the data on infection and rejection from our colleagues in the Czech Republic. And so Yuri Fronek, Dr. Fronek is a transplant surgeon and one of the primary architects of the Czech experience, which I believe outside of Sweden represents the dominant European experience with uterus transplantation. There's a couple of points that I'm going to make off of this slide. They've done 10 of 20 uterus transplants at the time of publication of this article. And you can see in particular this column here regarding infection as well as CMV status. And so the Czech group has actually done 2 transplants, 4 and 6, in a positive, from a positive donor to a negative CMV negative recipient. I would say this practice has not been widely adopted, certainly here in the United States, where most programs are excluding this type of transplant because of the potential complications due to CMV infection, particularly in pregnancy. Nonetheless, this group performed those transplants, and you can see here as listed under this infection column, they've had, whether it's positive to positive or positive to negatives, they've seen CMV replications. So CMV is definitely something that is of concern to us, in particular in uterus transplantation, and it's something we keep a close eye on. There have been, to my knowledge, no clinical consequences of the CMV replication. So in particular, no evidence of invasive CMV disease, but it is something that is, I think, particularly challenging to our field compared to others. And that's primarily, as Teena might allude to later, because the medications we would use to treat those CMV infections are really not indicated or safe, known to be safe in pregnancy, and that's a problem. So you can see here some other infectious complications that I won't dwell on much, a variety of urinary tract infections, some Clostridium difficile. So in short, infection is something we certainly see in uterus transplant candidates, although I will say that, again, the US experience has not replicated this, and largely for reasons we don't understand, the US patients have not had nearly as many infectious complications as this particular group. Nonetheless, it's certainly a possibility and something that as clinicians caring for these patients, we are concerned about all the time. You can see a fair amount of leukopenia here as listed as well. Again, this problem has not been as significant in the US patients to my knowledge. It certainly was not the case in my experience taking care of the pen transplant recipients. And then you can see all of the rejection over here. And so I'm going to leave much of this discussion to Teena. But in short, despite the fact that certainly in the group, in the hands of the Czechs, were certainly using quite a bit of immunosuppression as evidenced by these infectious complications, but rejection, of course, still does happen. And I should mention that the way we monitor for rejection in uterus transplantation is with biopsy of the cervix. We have no biochemical parameters such as the creatinine or the LFTs that we can follow. And so the diagnosis of rejection is based off of protocol biopsy. Again, this varies, the approach varies from institution to institution, but on average about once a month or once every other month in stable patients, we perform that cervical biopsy, including in pregnancy. I'm going to move over to some of the complications we've seen with kidney function, because I think this is a very special topic when it comes to taking patients through a safe uterus transplant and a safe pregnancy. These are data that my colleagues, Dr. Sawinski and Dr. Johannesson, along with some of our collaborators in the global community, put together. And you can see here, I'm showing you a bar graph of GFR as you march through a uterus transplant experience, both pre-pregnancy as well as at the time of embryo transfer, and as you go through this. And I want to first of all educate this audience that this slide is misleading. And because what you initially see is that the GFR comes down a bit, but initially you're thinking, oh, well, that's not too bad, right? Maybe you're moving from 100 to 90. But what is missing from this slide is what GFR should do during normal pregnancy, which is actually to go up. So I just want to emphasize that this decrease in GFR, while mild, is actually quite significant, because where this GFR should be is way up here. There should be a line up here that represents what normal is outside of uterus transplantation. And the consequence of this renal dysfunction is not known in pregnancy, but I will share with you that I think the obstetric literature would support this conclusion as well. We think that this is a setup for some of the complications that I'll talk about on the next slide, which is, for example, preeclampsia or some disordered placentation. So this is a problem when we see this drop in GFR from normal, even if it does not fall into the range of severity that many of us on this call or on this webinar are familiar with treating. And you can see here what happens, we think, in this very small cohort of about, I think, 16 transplanted patients who've gone through pregnancy, what happens after the hysterectomy. And of course, as a reminder, at hysterectomy, we stop the immunosuppression. And so you can see that luckily this GFR does seem to come back up. And to my knowledge, there's been no long-term consequences of this dip in GFR under cover of immunosuppression. Presumably the CNIs are doing this, but we do not know for sure. Time will tell. But again, we are early in this field, follow-up is limited. And so whether or not there is any, I'll call it, effect of this renal dysfunction later in life for these candidates remains, or for these transplant recipients, remains to be seen. I'm going to move through the next slides relatively quickly, but they're all going to focus on some of the pregnancy complications that we see. And much of the data that I'm going to show you are going to discuss pregnancy complications in solid organ transplant recipients, specifically kidney transplant recipients, from this lovely paper from Deshpande and colleagues, and that was published in AJT about 10 years ago. And in this paper, they performed a meta-analysis of kidney transplant recipients who had reported their pregnancy outcomes to one of several different registries, and obviously surveyed the literature, which was either comprised from individual centers or from centers who had mined these registry data. And so while I won't go into the details of all the studies that were included, you can see from this very kind of popular graphic that we use to describe risk as we understand it from meta-analyses. You can see that for gestational diabetes, that the kidney transplant recipients had a twofold increase over the general population in their rate of gestational diabetes. And I should mention that the red line here on the next slides that are derived from this paper indicates that rate of, for example, gestational diabetes in the general population compared to what was found in these variety of studies. Preeclampsia is a big problem in organ transplant recipients who go through pregnancy, and your eye can already show you this by the litany of studies that have results up above the red line representing normal here. So we think there is a 6-fold increase in the rate of preeclampsia in recipients of kidney transplants versus the general population. So that is not a subtle effect. That is a big problem. Preeclampsia, as many of you in this audience knows, is I'll call it a function of disordered placentation. It's a disease that affects, obviously, as the slide says, about 5% of the general population, and is really associated with problems caused by hypertension out of control, which can lead to eclampsia, seizures, and even death of the mother. In this day and age, preeclampsia is still a very severe disease, but is usually intercepted and managed very well by our obstetrician colleagues who can deliver mom before preeclampsia moves to eclampsia, but it still causes maternal deaths even in this day and age among those who have access to care. Preterm birth, the rate of preterm birth in kidney transplant recipients also much higher than the general population, as you can see here. And then moving on to this slide about gestational outcomes, what I'm showing you here are 2 figures from the paper that show you the gestational age outcomes of the babies, as well as their birth weights. And this is summarized down here so you can see, for example, that the kidney transplant babies or kidney transplant moms have their babies at an earlier point in gestation on average, about 35 to 36 weeks, compared to term in the general population. And these babies are born smaller. And if any of you are obstetricians on this webinar, I will tell you that I do not know from this paper on the methods if this 2,400 grams was adjusted for the early age of the babies. In the uterus transplant patients, I will mention that their outcomes look very similar to this. So for example, the average age that a baby from a uterus transplant recipient has been born is at 35 weeks, and they're around this size. But this size for this age range is appropriate for size. So this does not represent intrauterine growth restriction. That said, intrauterine growth restriction is still a complication that is more frequently seen in transplant patients. Whether it is seen as well in uterus transplant recipients, we do not know yet. And I wanted to end this portion of our review of complications really specific to uterus transplantation by coming back to the specter of preeclampsia. As I mentioned, the average age of a baby born to a uterus transplant recipient is at 35 weeks, and the vast majority of those births are driven by, I'll call it a maternal indication. And so many of these have been driven by the development of preeclampsia in particular. So as I mentioned, Dr. Sawinski and my colleagues have a manuscript in preparation. We found in the cohort of 16 patients that I already showed you data from, derived primarily from these centers, that the preeclampsia rate was about 25%. So again, you can see that that number doesn't vary much from the kidney transplant data that I showed you a few slides ago. Teena already mentioned this paper, this review of uterus transplant outcomes for the first 45 patients transplanted by Jones and colleague from the UK. And from the 18 births here, we see a rate of 33%. And that's reported again with Actually, I will mention this paper did not include any of the data from Cleveland or the University of Pennsylvania. So there were not many outside of the Baylor group, and that only includes, I'll call it the earlier data points from the Baylor group. This review does not include much of the United States experience. And then Dr. Johannesson from Baylor has published a paper that I apologize I didn't cite here. I believe it was an age 18, maybe Teena can remember this better than I can right now, but their cohort of patients has had a lower preeclampsia rate. And again, we don't know, we don't biologically understand the underpinnings of preeclampsia very well. We certainly don't understand all of the factors in transplant recipients that drive this up. And so I'm remiss, I cannot explain for you why there's such variation in this preeclampsia rate, but I think we could all agree that it's higher than the general population and something to bear in mind. So Teena, back to you.
Thank you, Dr. Porrett. Now, having understood the risks to consider with immunosuppression, we will review the current state of immunosuppression management and other considerations after uterus transplant. Now I'm going to take it back to Dr. Shah for our next polling question.
Thanks, Dr. Sam. So our next question is, what are the measures of success after uterine transplant? And the options are recipient survival and quality of life, donor survival and quality of life, pregnancy outcomes and live birth, fetus child survival and quality of life, and all of the above. Please put in your answers in the polling question tab.
Wonderful. So majority, 85% said all of the above, 15% said pregnancy outcomes and live birth. I don't think any of them are wrong, but I hope to show that all of them truly are measures of success. So what does success look like in uterus transplant? Now, the ultimate goal that we all talk about is live birth. However, key components of success still include donor outcomes. This is why, especially with live donors, where we're exposing otherwise healthy individuals to surgical risks and hysterectomy risks, it's very important that we ensure risk is minimized. Success also means minimizing risk to the recipient. So recipient outcomes, graft outcomes, and maternal complications, which Dr. Porrett just reviewed, is very important as well. Fetal and newborn outcomes are very critical. So not only do we want live births, but we want the birth of healthy babies. In fact, OPTN, which I know Dr. Porrett has been a part of this advisory group, but OPTN has proposed new data reporting requirements related to outcomes of children born to uterus transplant recipients to further provide insight into post-transplant outcomes beyond live birth. It's important to note, as Dr. Porrett mentioned, that unlike kidney transplant, for example, which is where we see a lot of the data with pregnancy outcomes, but unlike kidney transplant recipients, uterus transplant recipients typically do not have other significant comorbidities. So we don't expect that they would have, or we expect them to have lower rates of complications such as preeclampsia, low birth weight, and prematurity. But this also highlights the need to ensure that we're balancing risk versus benefit in this population. And this is why, monitoring outcomes, even though currently it's voluntary, but monitoring outcomes in a systematic way is very important to make sure, we are carefully employing immunosuppression and maximizing our success rates. Now, a lot of our pharmacists in the audience will say, and I agree, that pregnancy categories are outdated. However, even though these FDA letter pregnancy categories have now been replaced by more specific language, I still like to refer to them because I think they can be helpful in kind of a big picture view of the level of evidence and general approaches to medications in pregnancy. But as we go through some of these medications, you'll also see why the FDA removed some of these labels to have better risk-benefit decisions and better shared decision-making with patients. So in the historic categories, we have category A, which signifies that no human risk has been found in studies. Category B, which includes medications like prednisone in lower doses. This is where animal studies have failed to demonstrate risk to the fetus, and there is insufficient data in humans. For category C medications, these include our calcineurin inhibitors and our mTOR agents. These have shown adverse effect to fetus in human studies, but there is insufficient data, or adverse effect in animal studies and insufficient data in human studies. So here, potential benefits may outweigh risks. Category D is where it gets, where the FDA category may not be sufficient to really help provide a good approach, and where we need better clinical summaries. And that's where we'll go through in the next few slides. But category D is where there is human fetal risk that has been demonstrated. The examples that we have in transplant are mycophenolate and azathioprine. Benefit may outweigh risk in severe or life-threatening life-threatening situations. And lastly, we have X, which is where medications are contraindicated. For the sake of time, I'm going to go through the next few slides fairly quickly, but we will review the risks in detail of some of our common immunosuppressive agents. First, we have steroids and calcineurin inhibitors. Both of them do cross the placenta, or all three of them. We have steroids, cyclosporin, and tacrolimus. Cyclosporin and tacrolimus being our calcineurin inhibitors. All are pregnancy category C. All have been demonstrated to result in decreased birth weight and premature birth, as we saw in Dr. Porrett's slides. Of note, with steroids, there has been a link to cleft lip plus minus cleft palate. However, this link has been inconsistent across studies. There are many confounding variables to some of these abnormalities, including the decreased birth weight, which may also be related to predisposing maternal conditions. So that's something to keep in mind. But generally, these medications are safe to take in pregnancy. Of note with the calcineurin inhibitors, and this is an area where we really want to, again, keep monitoring our outcomes and ensure that we are minimizing risks. But given cyclosporin in particular increases the risk of hypertension and tacrolimus increases risk of diabetes, we certainly see with both of these medications the need to monitor hypertension, particularly with the risk of preeclampsia in pregnancy, as well as maternal hyperglycemia. Our next few medications are anti-metabolites. Both of them, azathioprine and mycophenolate, are pregnancy category D. But the difference is that azathioprine, while it crosses the placenta, does so in an inactive form. And so the fetus lacks the liver enzyme to convert to the active form. It has been found to be teratogenic in rats, but only at high doses, so not in doses that we typically use in transplantation. This azathioprine is typically what we use when we are transitioning from mycophenolate to an alternative antimetabolite in pregnancy. Mycophenolate, on the other hand, has a FDA REMS program. So it has a black box warning due to its risks of first trimester pregnancy loss, congenital malformations, which include facial abnormalities as well as organ abnormalities. So it is crucial to discontinue at least 6 weeks prior to conception and switch to an alternative such as azathioprine. We have less data with mTORs and co-stimulation blockers. They are pregnancy category C. There has not been reported increased risk of birth defects with the mTORs, although most of the data has been with sirolimus. Belatacept, while it has been found teratogenic in animals, it's only been at high doses, but there have been case reports of successful pregnancies without complications in the setting of belatacept. Of note, belatacept is weight-based, and we'll see later how pregnancy increases our total body water. So it's important to ensure dose is adequately adjusted with weight gain in pregnancy. Now, rejection can be a challenge after uterus transplant and in pregnancy in general, as the data for our anti-rejection agents are limited. But typically, first-line agents that we'll see being used are steroids, which we've reviewed earlier as being safe in pregnancy, Antithymocyte globulin in particular has been used in steroid-resistant pregnancy. While there is insufficient data, there are some case reports that have been shown to not have any fetal abnormalities, but it is something to keep in mind with rejection treatments to weigh risk versus benefits. Of note, bortezomib is category D and does have links in animal data for potential for fetal harm at lower than normal dose. The rejection experience so far, we can see in that Jones and colleagues paper of the first 45 cases where they had 45% of patients experience 26 rejection episodes, majority of which were confirmed on histology, so with cervical biopsies. 2 were confirmed based on clinical findings. Majority of these cases were grade 1, which are mild. They were treated with steroids as first-line treatment, and it was only in steroid-resistant or severe, which is grade 3, where antithymocyte globulin is used. And that has been the practice for most uterus transplant centers, where steroids are used first-line, particularly to weigh risks and benefits of our rejection therapies, as we just reviewed earlier. I do want to review our Baylor Dallas experience. One of our wonderful transplant pharmacists here, Dr. Wilson, presented our experience with immunosuppression at the 2021 American Transplant Congress. This analysis included 20 uterus transplant cases performed as part of our DUET trial. Patients who had grafts removed within 30 days were excluded. The remaining 14 patients were grouped into those who had rejection versus those who did not. As you can see here, baseline characteristics were similar with overall low immunologic risk. The anti-immunosuppression regimen utilized in this cohort of patients included thymoglobulin at a cumulative dose of 4.5 mg per kg per ideal body weight, which is more consistent with kidney transplant practice. Majority of these patients were on tacrolimus and azathioprine, with 1 patient on tacrolimus and everolimus. The average trough levels pre-pregnancy, during pregnancy, and postpartum ranged between 5 to 8 nanogram per milliliter. Of note, only 1 patient, that's patient number 20 in the chart, experienced rejection during pregnancy. We see in patient number 5 here in the chart, we did have that 1 patient who ended up getting, was able to have 2 pregnancies from her uterus transplant. Of note, rejection incidents did not lead to any difference in outcomes, including live births and miscarriage. Of note, one thing we really wanted to look at too was DSA development, which was very low, and no recipient deaths in this case. As a result, induction with thymoglobulin, maintenance with tacro at trough levels of 5 to 8, and azathioprine resulted in excellent live birth rates. In general, our pharmacotherapy approach will include antifungal and antibacterial prophylaxis, thromboprophylaxis given the risks of infection and thrombosis, CMV prophylaxis and PGP prophylaxis, and ensuring we're stopping teratogenic agents such as mycophenolate and CMV prophylaxis prior to embryo transfer. Of note, our group published on being able to shorten the time to embryo transfer by using de novo tacrolimus and azathioprine and avoiding mycophenolate, which allows us to shorten time to embryo transfer to as low as 3 months rather than the traditional 6 to 9 months. We'll take it back to our polling question.
I think for the sake of time, we can
do you want to skip it?
Yeah,
perfect.
Just skip it, yeah.
Perfect. So there are several physiologic changes in pregnancy to consider, including increased elimination and renal clearance. There are also multiple fluctuations in our cytochrome 450 isoenzymes, including 3A4, which metabolizes tacrolimus, cyclosporin, and our mTORs. And so with the case of tacrolimus, it's important to consider that tacrolimus is a 3A4 substrate and highly bound to plasma protein and erythrocytes. But in pregnancy, your 3A4 activity increases and your production of albumin and red blood cells decreases. As a result, while there are lower whole blood concentrations and an increased daily dose need of 20 to 30% to maintain pre-pregnancy whole blood levels, there is a risk of increased free drug levels. As a result, some recommend considering monitoring free drug levels or carefully monitoring whole blood levels, as well as monitoring for toxicity. With breastfeeding, of note, there's generally low drug exposure with our commonly used agents, including steroids, CNIs, and azathioprine, but limited data with mycophenolate, mTORs, and belatacept. And lastly, we're always trying to figure out how do we improve and how do we go forward. We talked about some of the risks with nephrotoxicity. And so in the future, we hope to see more innovative immunosuppression protocols to really help us minimize that risk. In conclusion, uterus transplant has been demonstrated to be a feasible option. Considerations must be taken to minimize risk, and we still need long-term data to further refine this field. With that, I'll open it back up to Dr. Shah.
Thanks, Dr. Sam, for the excellent presentation, and Dr. Porrett for the excellent presentation. And we can take a few questions right now. We are nearing our time, so we just have a few minutes for questions. I think first of the one question which I saw was, what are the target levels for the tacrolimus dosing, which I think you did answer, but Dr. Sam, you can talk about it again. Since it was asked by one of our attendees.
Sure. I think it has ranged based on the literature. I know in the Swedish group, they did about 10 to 15 early on, and then 5 to 10 after 3 months or so. At Baylor, we target about 5 to 8 throughout pregnancy. And we've seen that does produce, minimize risk of rejection and produce good birth outcomes.
Great.
Dr. Porrett, is that what you've seen as well at your center?
Yeah, at University of Pennsylvania, when I was there, we would target higher levels of tacrolimus, and I personally think that was a mistake. And towards the end of my time there, and certainly here at UAB, we're going to be targeting levels like you mentioned, Teena. I would also caution the audience or remind the audience to know that 5 nanograms per mil on the lower side, it's important in pregnancy that you make sure you test those levels frequently, because kind of the dropout, the fallout at the bottom that Teena had mentioned, because of those the physiologic changes in pregnancy and how one metabolizes these drugs, can be really problematic. And I'm sure that Dr. Shah and others, transplant professionals who've managed pregnant patients with their transplant, have seen this phenomenon before. So I think 5 to 8 is a good recommendation, but beware that lower end.
Thanks, Dr. Porrett. Yeah, that's right. We do target like around 5 to 8 sounds a good level to target. I think this is another interesting question, and I had the same question. What is a typical live donor for uterus transplant? What all you look at, age, previous children, etc. And maybe Dr. Porrett can answer this question.
Sure. So, and Dr. Sam, please jump in here, because I know that the Baylor group has done so many more living donors than we did at Penn. But in short, again, some variation, not exactly a consensus across the global experience, but living donors are typically saints, right? And incredible altruistic individuals. They can be altruistic living donors, non-directed living donors, as well as directed donors from such as a mom, for example, which was very common in the Swedish group. There are women generally of reproductive age, women who are obviously done with their childbearing. And so in practical terms, this is usually someone in their late 30s or early 40s. There are tremendous amounts, I'll call it, the selection criteria are very stringent here, but in general, they have to be healthy individuals who are done with their childbearing. But there have just an interest out of the sake of interest, some of the Swedish living donors were quite a bit older, actually, including one who at least one who was postmenopausal, and so menopause is not necessarily a reason that a uterus won't work when it's put into the right hormonal environment. So, but I think that the U.S. centers have been a little bit more reluctant to take on living donors in that age category.
Okay, great. Thanks, Dr. Porrett. Our next question is, what ethical reviews have been done by the community about the use of this new transplant? What comes to mind while we perform this? This is an amazing new option, but when we are so behind in access to basic public health, medical care, and the immense resource this require, is there where we could spend our resource? Dr. Sam, maybe you can take this question, and Dr. Porrett, you can chime in as well.
Yeah, I think this has been a evolving conversation, and there have been multiple ethical considerations, both from the community, non-transplant community, and the transplant community, especially as this is such a new procedure, and certainly, especially when you have living donors in the mix as well, you're increasing that risk to healthy living donors. One of the things, at Baylor, for example, we've now, we went live with the first commercial transplant. And so it's something that has come up is how do we ensure we're balancing risks and benefits, and ensuring that we are providing access to care for these patients who normally wouldn't have any other choice, right? Like for many of these patients who have fertility, they are having to go and spend enormous amounts of money for IVF and various other resources. So I think it's certainly an important consideration, and it's one that continues to be face forward, and we're trying to really help increase awareness to ensure that we can really get some insurance coverage in these patients.
Yeah, I've got a few things to add. Thank you, Dr. Sam. That was fantastic, and thank you to the individual who proposed this question. Is a central question in what we do, and I think there's a couple themes I want to introduce the audience to just very briefly that I've been educated about in my journey as a transplant professional now engaged in uterus transplant. First and foremost, it's important to remember that what we are fixing here. So uterine factor infertility and fertility in general is a disease that affects an individual's reproductive autonomy. And I want everyone to think very hard about what that actually means. So reproductive autonomy, the way that I think about it, is really a basic fundamental human rights, right? We get to decide when we become pregnant, who we become pregnant with, what time that happens in our lives. And when this choice is taken away from individuals, it's extremely problematic. And as such, certainly with, again, there are many individuals who would comment more intelligently than I can about this, but there is tremendous psychologic disability as well as physical disability that occurs with infertility, which I think has not been well measured, at least in a way that the transplant community can respond to. And so as a consequence of this question and others, I think there's a tremendous opportunity, in fact, not just an opportunity, but a necessity for all of us to build the case for the value of uterus transplantation in particular, so that we can actually measure the disability that I described in a way that can respond to this and help us frame where uterus transplant should sit in the suite of services that we provide as medical professionals.
Thanks, Dr. Porrett. I think we will end our webinar right now because we are close to our time. And again, I would like to thank the American Society of Transplantation for giving us this opportunity. I would like to thank our speakers, Dr. Teena Sam and Dr. Paige Porrett, for giving such a wonderful talk, and all the attendees for being a part of this webinar. Please feel free to post the other questions on the hub, and thank you again.
Thank you, everybody.
Thank you, everyone.
AST would like to thank our panelists and moderator and all of our attendees for being at today's session. Please remember to complete the evaluation survey. We will also be posting the recording to the TX PharmCOP, VCA, AC, and HUCOP hubs. And thank you again to our presenters and the audience, and have a great afternoon.